So I'm Ross Williams. I'm a PhD that's working at Erasmus Medical Center in the Netherlands, and I'm going to take you through our second prediction question. So this was building upon the idea that Jenna touched upon, is that we're looking at the decision points that doctors have to make with the initial treatment. And if we can go to the next slide. We'll know that a large proportion of the patients presenting with symptoms will actually be sent home. However, we've seen a couple of sad cases with the COVID-19 of patients who have had an healthcare interaction and have either been sent home or have not been admitted to hospital, then having quite a severe disease progression. So one thing we were trying to do is to build a model that can act both as a safety net for a clinician and also as reassurance for a patient. So the idea here is that a clinician will make the decision that a patient is either not serious enough or will not progress to be serious enough to need a hospital admission, and as such will send them home. And then if we can give them this model and then it shows them that it's a very low chance of that patient actually coming back for a disease progression, then that's nice for the clinician to know. And the other side is that given the current status of the COVID-19, I think a lot of people are very worried about this, and if they hear that they are not serious enough to be admitted, then maybe they would like a little bit of extra reassurance. And if we can show that actually we've seen patients like you before, and in almost all the cases, and we can show you've got a very, very low risk, it just adds a little bit of reassurance for patients, which I think in these times can be really helpful. If we move on to the next slide. So I'll talk you through our cohorts for this. So first of all, we have a visit with either COVID or influenza with symptoms, with no pneumonia and that is not admitted to hospital. And then we decided to have another cohort as well where the patient does have pneumonia. So what we wanted to see here is what the difference is in the decision-making ability that we have if we have a confirmed pneumonia versus confirmed no pneumonia. And then we looked at two different outcomes. So one was pneumonia or a couple of other more serious progressions of pneumonia. And the second one is the same, except we also included death in this outcome. And I'll make a mention here of our time at risk, which starts on day 2. So we decided to do this because we wanted to be sure that these patients were sent home, because there's obviously there can be situations where a patient comes in and they're not admitted to hospital until the next day. But we wanted to make sure we weren't including these, so we have a time at risk that starts at day 2. And then if we can move on to the next slide, I will be able to share my screen with you. And now you should be able to see a similar app to the one that Jenna just showed you. However, this time we're looking at the second question. And what we can see here is, so with analysis 1, so this is for patients who have a pneumonia and then they're sent home. We have an AUC of about 0.75, which is, I think, pretty good for us, and I think we're quite pleased with this. But what we also see is that if a patient is sent home without a pneumonia, we end up with an AUC of 0.86. So what this means is that we're slightly more sure about our prediction model for patients when they're sent home with no pneumonia, and that it makes this is a slightly easier problem to predict. And if I go and look at the performance, one of the things we can see actually is that the end of the ROC curve is very high. And this means that for patients who we say have a low risk, there's very, very little chance of them coming back. So we're really sure about patients in this area. And actually we see quite a steep increase as well. So when we look at patients that we see as the highest risks, we're also doing quite well at saying, well, maybe we need to have a second thought about these patients. One thing I will mention for this is that we have quite a low incidence rate. So our precision recall curve is a little bit further down, but I think that because of the nice AUCs we've got, these are still good candidates for application in the hospital. I'll also mention, so we've had one external validation come in, and these seem to suggest that the numbers we got originally are consistent, and as such, I think we're starting to get some evidence that this could be a reliable model. The other I will look now at the other outcome that we looked at. So this was the one where we didn't include death, and we see a little bit of reduction in the performance of these. I'm wondering whether this could possibly be because we're missing some of this information. So maybe we've sent patients who are high risk home, who have died at home, unfortunately, and this is then not captured in this outcome. But I think still AUCs of 0.73 and 0.83, and again maintained across the external validation, suggests that this could be a very usable model. And now if we can go back to the next, if we go on to the next slide. Yeah, so I'll just quickly discuss what the next steps for this prediction problem are. So first of all, we want to validate this model in a COVID-19 data set. So obviously we've developed basically on influenza or flu-like patients. So whilst we've got very nice models there, we really need to see how this will validate when we move into the COVID-19 space. We also, again, for this want to create a more parsimonious model, because this will then help out also with our tool creation, because then if you can make it so, I think this model currently has about 200 covariates in it, which is sort of very unfeasible unless you have a direct interaction with the healthcare system. So we would ideally make this into another smaller model, and that's the next step for us to do, and to then externally validate that. The tool creation, which is how can we best present the model? So is this with some kind of application? Can we make a nomogram? Can we make some sort of chart where you can fill boxes in to increase the usability of it? And then we will also be moving on to the model dissemination.